Welcome to this very exciting and important webinar. My name is Chris Morrow. I'm an emergency physician, previously trained as family and practice rural family medicine as well, and lucky enough now to be the executive medical director at UBC CPD. And I'm happy to welcome you to this very important and well-attended webinar. I'm very excited to tell you that we have nearly 500 registrants from coast to coast to coast, which is really great. And we're very fortunate to tonight be joined by Kevin Qamaniq-Mason, who is here to educate us on this topic and also hopefully answer some questions. First, I'd like to begin by acknowledging that the land on which the UBC CPD office resides is on the traditional and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. And I'd also like to recognize that you all are joining us from many different places, and I would encourage you to think about your land and the traditional owners and caretakers of those. I'm personally calling you from what is colonial known as Victoria, but is the territory of the Wet'suwet'en speaking people, so the Songhees and Esquimalt, as well as Wasanik. And when reflecting on land and the land acknowledgement, I always like to try and relate it to what's happening around us. And thinking about the Inuit right now and the political climate is quite striking that our government is needing to state that they're going to exert or clarify our sovereignty in the north, and that is a very complex concept when you think about the impact it must have on the Inuit. And in addition, it might be a little bit strange that we're standing up saying we're defending their land. So definitely complex considerations when thinking about land. I'd like to thank the Doctors of BC Indigenous Anti-Specific Racism and Cultural Safety Team. With this support of the Joint Collaborative Committees who have collaborated with UBC CPD to support the education development of this webinar series. This is a 90-minute webinar. We're going to have opportunities at the end to have questions asked, and we'll be using slido.com to do that. You can access Slido by scanning the QR code shown on the screen, or go to slido.com and enter the event code ISARCS, so ISARCS, that's ISARCS, or you can find a direct link in the email invitation you had for this webinar. Please try and upvote questions that are suggested. We often get quite a few questions, and if you can give them a thumbs up, they'll rise to the top as the more popular questions that need to be answered, and hopefully we'll get to those. If you do have technical difficulties tonight, it's not to worry. We will be recording and sending a recording with a link and any other resources to you later at a later date. And at the end of this session, please remember to take a few moments to complete the attendance and evaluation forms. You can access these forms also by the email you received for this session. And a reminder that for participating physicians to obtain study credits, you do need to fill out the online attendance form. Next, you'll see our learning objectives for tonight. You can have a look at them yourselves, but basically, in a nutshell, describe Inuit cultural norms, values, and communication styles, apply the learnings to build effective and respectful relationships with Inuit patients, and use a toolkit to provide and navigate culturally diverse environments. So without further ado, we are very lucky to have Kevin Qamaniq-Mason presenting tonight. Please take a moment to review the disclosures for the speakers and those involved in the planning of this webinar. And then I'll hand it over to you, Kevin.
Great. Thank you so much, Christopher. And great job with pronunciation of my last name. I know my last name can be a little bit tricky, but you did. I heard you practicing, and it sounded great. So I will do a brief intro before we get into the webinar. My name is Kevin Qamaniq-Mason. I'm originally from Igloolik, Nunavut, which is in the northern part of Baffin Island. I'm joining you all this evening from Ottawa, Ontario, where I've been living and residing in since 2009 on unceded Algonquin territory, unceded Anishinaabe territory. I'm of mixed ancestry. My mother is Qamaniq, who is an Inuk from the Igloolik area, and my late father was Marcel Mason, who was from Woodstock, New Brunswick, and he was of Irish descent. And I'll talk a little bit about my career. It's always been in some form of Inuit advocacy, whether it was providing frontline social services for the urban Inuit community here in Ottawa, assisting Inuit with housing, with food insecurity, or advocating on matters related to child welfare. I spent 5 years working at Inuit Tapere Kanatami, which is a national Inuit advocacy organization. And I formed my consultancy nearly 3 years ago, and I've been very happy to continue advocating for Inuit in my consulting work. I've been very fortunate that I've been able to make a career out of this. And I'm hoping to provide everyone with some useful tools for working with Inuit patients. I've developed this webinar. It's called Providing Culturally Safe Care for Inuit. You should see it on your screens now. So this is a cross-cultural competency or CCC workshop. Here are the topics that we're going to be covering. We'll start off with an overview of Inuit Nunangat or Inuit homelands, and then we'll lead into discussions on understanding the Inuit historical context, the Inuit cultural context, the current context, and then we'll finish off with some strategies for utilizing CCC to provide culturally safe care. Just some notes on respectful terminology when working with Indigenous peoples. There are 3 Indigenous groups in Canada, the First Nations, Inuit, and Métis. Each group is distinct with their own languages, traditions, customs, and culture. We'll get a clearer sense throughout the webinar of what I mean when I use the term culture. But since there are 3 Indigenous groups in Canada, the term Indigenous should only be used when we're referring to all 3 groups. So we should avoid saying things like Indigenous culture, especially if we're referring to a specific people's culture, Inuit culture, Métis culture, or First Nations. It's good practice to use specific terminology. If you can refer to a specific nation, that's always more helpful rather than First Nations culture, you could say Coast Salish or Anishinaabe or Ojibwe culture. It's good practice to use specific terminology where possible, rather than using like a broad monolithic term like Indigenous. Terms like Aboriginal and Native have fallen out of use, but we still see them in legal contexts, in legal documents. The term Eskimo is considered outdated and derogatory for the most part. There are, however, still some Inuit who quite proudly refer to themselves as Eskimos, while many others may find the term insulting or offensive. Better to just play it safe and to not use the word at all. In Inuktitut, words often have singular, dual, and plural forms. So Inuktitut is a language that Inuit in my part of Inuit homeland speak. So Inuk means one person, Inuk means 2 people, Inuit means 3 or more people. I'll be switching between Inuk and Inuit depending on the context. Just a quick note about the dual form. In Inuktitut, we only see the dual form used generally for things that come in natural pairs, like a pair of mitts or a pair of socks. Even though Inuk with the elongated U sound is technically correct, most Inuit won't use that. We typically just stick to Inuk and Inuit. And also, there's no need to say Inuit people or Inuk person for a couple of reasons. One, Inuk translates to person. The literal translation for Inuk is person, and Inuit literally translates to people. So saying Inuit people is a bit of a redundancy. Also, we don't say that someone is a Canadian person, right? Or an American person, or that a group of people from Alberta are Alberta people. We say Canadians, we say Albertans, we say Newfoundlanders. So it's not necessary to say Inuk person or Inuit people. It's not an offensive thing to say. I often say it myself. It's just a less correct use of language. In Inuktitut, we also have a word for people of European descent. And here are the singular, dual, and plural forms for people of European descent. So Kallunak, which means €1 Canadian, Kallunak with a K at the end means €2 Canadians, and Kallunat with a T at the end means 3 or more Euro Canadians. I'll talk briefly about Inuit Nunangat or Inuit homelands. Starting from an international lens, this is a map from the Inuit Circumpolar Council of Canada, or ICC. ICC represents the approximately 170,000 to 180,000 Inuit in Russia, Alaska, Canada, and Greenland, which is quite a small population. Zooming in to Canada, this is a map from Inuit Tapiri Kanatami, or ITK. This map illustrates the 4 regions of Inuit Nunangat, the 4 regions of our homelands. In the northern part of the Northwest Territories, we have the Inuvialuit settlement region, and then we have Nunavut, and then moving further east in northern Quebec, we have Nunavik, and then in Labrador, we have the Nunatsiavut region. So we should avoid what the term that we were using when I worked at ITK was Nunavut centricity. This notion that all Inuit come from Nunavut. Rather, there are different regions where we find Inuit peoples. This is a map from the 2021 census. Within Canada, there's about 75,000 Inuit. And about 30% of the Inuit population resides outside of Inuit Nunangat in urban centers like Ottawa, Montreal, Winnipeg, and Edmonton. There is a small growing pocket of Inuit in British Columbia. I met a couple of Inuit myself in September 2024 when I was in Victoria, BC. I was there to attend the Canadian Medical Association's apology to Indigenous peoples for historical and ongoing medical harms. So there is a small pocket of Inuit in BC. It is growing. Let's learn let's learn a little bit about the Inuit and Canadian historical context. This sort of frames where Inuit are today. Prior to contact with Europeans, we led a nomadic subsistence-based lifestyle. Our societies were organized into small kin-based groups. Cooperation and sharing were essential for survival. Igloos, sod houses, and animal skin tents were used for housing, depending on the season and the location. Dog teams played a crucial role in travel, in hunting, and in survival in general. And in terms of spirituality, we practiced shamanism, which was important for our spiritual life, for health, and our overall well-being. There were some brief and violent interactions between Inuit and Norse seafarers, commonly known as Vikings, sometime around 1000 to 1350 CE, when Vikings attempted to colonize parts of Baffin Island and Newfoundland. But it wasn't until Sir Martin Frobisher arrived on Baffin Island in 1576 when Inuit started having significant interactions with Europeans. On this particular voyage, the crew met, cautiously traded with Inuit, and kind of mysteriously, Inuit seemed to have some familiarity with tall ships. This a report from George Best, one of Sir Martin Frobisher's crew, shared that Inuit boarded the ship. They tried European food and wine and competed with mariners in acrobatics on the ship's rigging. Intermarriage and the impregnation of Inuit women by European whalers from the 16th and 19th centuries had significant social impacts in Nunavut and in other Arctic regions. These relationships, they led to cultural exchanges, but they also led to social stigma and discrimination, as well as disruptions to kind of time-honored traditional family structures and kinship networks. Additionally, this also led to the spread of diseases from European whalers, which further compounded these tricky social situations. It also led to health crises and, in some instances, significant population declines in many Inuit communities. The Hudson's Bay Company, which might be closing now, entered what is now Nunavut in the early 18th century. By the mid-19th century, HBC trading posts were well established along the coasts of Inuit Nunangat and major waterways. During this pre-settlement era of colonization, Catholic, Anglican, and Protestant missionaries settled at these trading posts as well as in whaling stations. Overhunting by trappers during this period led to decreased populations of many animal groups, which were important for subsistence living in the Arctic. There was a pattern that Inuit settlements typically followed, or settlements in Inuit Nunangat typically followed. Generally, Hudson's Bay Company would establish trading posts, or there would be whaling stations established. And if business was very good and Inuit were drawn to these posts, Inuit would trade furs for European goods such as metal tools, flour, sugar, tobacco. This would in turn attract missionaries, and then eventually the RCMP would establish detachments in these areas. Political pressures in the pre-war period led Canada to assert sovereignty over its high Arctic regions. Again, this is a bit of a tricky issue back then and still today. The 1934 Devon Island relocation saw the Canadian government forcibly move Inuit families from traditional homelands in the eastern Arctic to Devon Island. You can see on this map here on the bottom right of the screen, which is quite far up north. You can get a sense of what the landscape is like from that top right image. There were promises that Inuit could return to their home after 2 years. However, these Inuit families were further relocated to different areas like Arctic Bay, Fort Ross, before finally being settled in Spence Bay. And then on April 5, 1939, the Supreme Court of Canada decided that Inuit should be considered as Indians in the Constitution Act, thereby making Inuit the legal responsibility of the Canadian federal government. This was done to further cement Canada's claim to the Arctic, but after Inuit became the legal responsibility of the federal government, the government then had to address the challenges of administering to a remote nomadic community. In 1941, the government of Canada introduced Eskimo ID tags as part of the efforts to assert sovereignty and control over the Arctic territories. It allowed Canada to identify population sizes and the inhabited regions of the Arctic. Inuit had to show their ID tags if they wanted to access vital resources and services such as food programming, as overhunting led to an increased dependence on European goods. Inuit had to show their Eskimo ID tags if they wanted to access social programming and food programming. It eventually became a means of control and coercion, reinforcing the authority of government agencies and diminishing Inuit autonomy and the agency of Inuit. Traditionally, Inuit had only one name. We didn't have a first name and a surname. And Anglophones found our names difficult to pronounce. This was further complicated by the fact that there was no standardized writing system, and the Latin alphabet didn't really lend itself to Inuktitut pronunciation, so This is why the federal government started issuing Eskimo ID tags. Inuit in the Eastern Arctic, they had an E number. It was an E followed by 4 digits. You can see a picture of this woman here. She was from Pondinlet or Mittimatalik, so her E number was E6009. For Inuit in the Western Arctic, their numbers would have been preceded by a W. Following the end of World War II, there were continued efforts to demonstrate Canadian sovereignty in the Arctic. This led to the establishment of government-administered settlements, as well as resettlement programs. Settlement was promoted as a means of providing access to essential services like healthcare, education, and employment. This led to the establishment of permanent settlements and the relocation of Inuit from traditional lands to designated communities. And as Inuit began moving into settlements, overcrowding led to the spread of tuberculosis. There's still TB outbreaks happening in Inuit communities right now. But during the 1950s, at least 1/3 of the Inuit population was infected with TB. Approximately 4,500 Inuit were sent to southern Canada for treatment in TB sanatoriums, including unaccompanied children. About 500 patients never returned. Here's a picture of an Inuit family boarding the CD Howe. This was one of the ships that traveled up north. And when Inuit tested positive for TB, they would be confined within the ship, and they were sent to TB sanatoriums in the south. In 1951, Section 88 was incorporated into the Indian Act, and this granted provincial and territorial laws and regulation over matters concerning Indigenous peoples and lands, including child welfare. This amendment to the Indian Act would eventually pave the way to the 60 Scoop, as Indigenous child welfare became the responsibility of provincial and territorial governments. The High Arctic Relocation Program, also known as the High Arctic Exile, took place during the Cold War period because there was a lot of international interests in Canada's Arctic. There were interests from Russia, interests from the States, from Greenland and Denmark. Between 1953 and 1961, 92 Inuit, approximately 8 families from Inukjuak, which is up in northern Quebec, were relocated to Resolute Bay and Grise Fiord. They are the 2 northernmost communities in Canada. The relocation process was coercive, with promises of better living conditions and economic opportunities. But the reality of life in the high Arctic was very difficult, with extreme cold temperatures, limited hunting and resources. Many families experienced starvation, isolation, and cultural dislocation as a result of the relocation. Some families were eventually relocated back to their home communities, but others remained in the high Arctic. Inuit also attended residential schools. By 1964, about 75% of Inuit youth aged 6 to 15 were enrolled in these institutions. During this time, many Inuit families decided to move into settlements to be closer to their children who had been placed in residential schools. And then missionary influences, both in the settlement as well as in residential schools, led to a widespread conversion to Christianity, as well as a rejection of shamanism and other important cultural practices such as drum dancing and throat singing. And then there was what's called the dog slaughter, or the RCMP dog slaughter, which began in the late 50s as a means to enforce settlement living. Traditionally, dogs were important for hunting, for travel. They would pull our sleds. And so between the 50s and the 70s, estimates vary anywhere between 1,200 and 20,000 Huskies were slaughtered by the RCMP officers. Many Inuit were stranded in settlements when they came into town to do some trading, and they found that their dogs had been shot, and they had no way to return to their own camps. And even the Inuit who did find a way to get back to their own camps would find that their camps had been burned down. So the the efforts to move Inuit into settlements were quite thorough. During the 60s and 70s, many Inuit children were taken from their families and placed in foster care or were adopted by families in southern Canada. Authorities often justified these removals based on perceptions of cultural inferiority, poverty, or inadequate housing. Inuit have shared accounts of discovering that their children had been taken without warning and leaving them uncertain if they would ever be reunited. Children who were sent to southern Canada and forcibly adopted into new families continue to struggle with loss of culture, language, and identity. Some have returned and are trying to navigate the tricky social and cultural implications of being displaced from their traditional homelands, being raised in southern Canada and trying to reintegrate, and many never returned or were never heard from again. Project Surname was a government initiative in 1969 aimed at assigning standardized surnames to Inuit in Canada's Arctic. This essentially ended the 20-year practice of issuing Eskimo ID tags, but the project faced significant opposition from Inuit communities who objected to the imposition of not only Southern names, but Southern naming practices, as well as the loss of kinship ties associated with naming. This resistance led to a scaling back of Project Surname. Many Inuit continued to use traditional naming conventions or adopting surnames of their own choosing. Today, many Inuit families will use the first name of a father, grandfather, or great-grandfather as their surname. This is what my grandfather, Nathan Qamaniq, did. He was named Qamaniq, but following Project Surname, he chose the name Nathan for his first name and decided to keep Qamaniq as his last name. Between the 70s and the 90s, the Inuit political movement surged with activism, paving the way for significant milestones in Inuit rights in Canada's Arctic. Organizations like Inuit Teperi Kanatami and the Inuit Circumpolar Council championed Inuit rights and negotiated land claims agreements with the Canadian government. Agreements like the James Bay and Northern Quebec Agreement, the Inuvialuit Final Agreement, the Nunavut Land Claims Agreement, and the Labrador Inuit Land Claims Agreement. These agreements recognize Inuit rights to land, resources, and self-governance, as well as establishing a legal framework for Inuit land ownership. However, today many Inuit are struggling with social and economic inequities. ITK released this infographic back in 2018, which illustrates some of the disparities between Inuit and non-Inuit, including healthcare access. So here, according to this infograph, in Inuit Nunangat, there are 30 physicians per 100,000 people, given that there's about 75,000 Inuit in Canada. That means there's less than 30 physicians. Less than 30 physicians just in Nunavut alone, compared to 119 physicians per 100,000 in urban health authorities. Healthcare access, in terms of access to healthcare access means challenges in terms of access to health facilities as well as healthcare staff. Inuit communities are served by community health centers, which often struggle with staffing and infrastructure challenges. Specialized healthcare requires travel to urban centers like Edmonton, Winnipeg, Ottawa, and Montreal, as well as other urban centers as well. So this leads us into understanding the current Inuit cultural context. We have a sense now of what the historical context was like and how many Inuit are dealing with issues of intergenerational trauma, as well as mistrust of the Canadian healthcare system. So one of the ways that we can hopefully provide culturally safe care is to understand the current Inuit cultural context. But first, we need to develop a shared understanding of what we mean by the term culture. We hear this term a lot. We're hearing a lot of terms like cultural sensitivity, cultural safety, cultural competency, but what does it actually mean? This is an image of a cultural iceberg. At the tip of the cultural iceberg, which is just a small part of the iceberg, we have what we can call surface culture. These would be things like language, arts, and clothing and food. These are the aspects of culture that are very easy to identify and easy to define. And often this is what we default to when we talk about promoting culturally safe spaces. Maybe we can have some, indigenous artwork or indigenous foods. What we're going to try to get into is to learn a little bit more about deep culture, what's beneath the surface. These would be things like social rules, what's considered respectful in terms of personal space, what's considered good manners, how do we disagree, how do we cooperate, and how do we make requests. Essentially, we're trying to figure out what are the unspoken rules that people follow, which dictate what is considered acceptable and unacceptable behavior. What are the protocols that people follow when interacting with other people? So in cross-cultural competency, or CCC, there's this academic definition of what culture means, the programming of the human mind by which one group of people distinguishes itself from another group. Another very nice, concise definition I've heard of culture is how we see and how we do things. Culture often gets complicated with things like identity, with ethnicity and nationality. So let's define these terms as well. Ethnicity refers to people who identify themselves based on ancestry. This is what ethnicity technically is your ancestry and your ancestral heritage. Culture refers to the shared beliefs, customs, values, and behaviors of a group of people, including social norms. Nationality is essentially a legal status that identifies a person as belonging to a specific country. Nationality is political and legal. Nationality can change if someone becomes a citizen of another country. For the purposes of this webinar, when I use the term culture, generally what I'm using when I use the term culture, I'm referring to sets of social norms, the unspoken rules that guide how people behave in a group. Within the Inuit context, we also have to consider Inuit Qawimaya Tuqangit. We can call these IQ. Qawimaya Tuqangi is a bit of a difficult word for most people to pronounce, but IQ is an Inuit knowledge framework that guides Inuit values, behaviors, and ways of understanding. Similar to, say, the Anishinaabe Seven Grandfather Teachings or the Coast Salish Teachings of the Longhouse or the Lakota 12 Virtues. So here are the 8 IQ principles. I'm not going to spend too much time on them. I do want to bring everyone's attention to these 3 points: Inuqatigit respecting others, Tunganangnik, which means fostering good spirit by being open and welcoming, as well as Ayikatigingnik, which is decision making through discussion and consensus. We'll see how these 3 values manifest in terms of Inuit social norms. One of the other resources that I often use as well is this guide from Pauktutit Inuit Women of Canada. They are a national Inuit women advocacy organization. They released this guide in the early 80s and released a revised version in 2006. In this guide, there's this Inuit notion of non-interference. Inuit place a high regard on the right of individuals to lead their lives free from interference from others. This belief strongly affects the way Inuit interact with each other. Keep this Inuit notion of non-interference in the back of your mind as we go through these CCC concepts. One of my other favorite CCC resources is the culture map written by Aaron Meyer. I often reference this. Many of the CCC tools in this workshop are adapted from this book. This book has some limitations, however. When examining Canadian cultures, Meyer is in fact examining Euro-Canadian culture. She doesn't make a distinctions between the different cultures in Canada, Euro-Canadian, Indigenous, as well as other cultures as well. So there is that bit of a limitation, which is why I had to adapt some of the material. CCC was developed in the 70s, and it's widely used in international business to foster profitable corporate relationships. CCC is very nice because it gives us a framework for comparing cultures, and it can be applied to build mutual understanding in multicultural settings like Canada. It does have some limitations, however, as it tends to focus on broad population trends and broad social norms. It cannot account for individual differences in behaviors. So CCC relies quite heavily on generalizations, which can lead to stereotyping or labeling. Today, we're going to be using CCC to compare Inuit and Euro-Canadian cultures. So just in case anybody has any questions about the term Euro-Canadian, Euro-Canadian refers to Canadians of European descent. When we talk about Canadian culture, things like Canadian politeness, right? That's a bit of a Canadian stereotype. Or the norms in a typical Canadian workplace, generally we're referring to a set of Euro-Canadian social norms, which most people, even people of different ethnicities, follow on a day-to-day basis. So I use the term Euro-Canadian because it's neutral. It's also a respectful term. It's accurate, generally self-explanatory, but it doesn't come with the baggage that words like white or Caucasian does. White is a racial term. It lacks cultural specificity, doesn't account for diversity of European, North American, Australian, or other backgrounds. Settler and colonizer, I typically don't use those words. They have a specific historical meaning. They do have a place in with regards to reconciliation and some other dialogues, but these terms are really related to systems of oppression rather than everyday cultural behaviors. So Euro-Canadian focuses on cultural identity, as well as the social norms that Euro-Canadians follow, rather than on race or historical roles. It's a nice, precise, and neutral term that we can use to compare cultures. When studying CCC, we define two ends of a spectrum. We can call these scales or dimensions or continuums. And after we define the two ends of a spectrum, we determine where a culture is likely to be situated. The first scale we're going to look at is the communicating scale. So we'll define low context communication, and then we'll define high context communication afterwards. Low context communication relies on explicit, clear, and direct verbal expression. Meaning is conveyed primarily through words. Messages are understood at face value. It's okay to repeat yourself if it clarifies communications. Generally speaking, low context communicators tend to be more task-oriented. And for low context communicators, when you're coordinating, it's important to be clear with what you can and can't do. So it's usually okay to be clear with refusals. On the other side of the communicating scale, we have I'll provide some examples of what low context communication might look like in the healthcare system. Your test results show that you have type 2 diabetes. This means your body is not using insulin properly, and so on. In these two examples, you can see that when we talk about low context communication, really we're talking about clear, exact language that is very specific, and there's no ambiguity. It's not necessary to read between the lines. On the other side of the communicating scale, we have what's called high context communication. This type of communication relies more on surroundings, context, nonverbal cues. Meaning is conveyed through implicit understanding, shared experience, and context. In high context communication, messages are both spoken and read between the lines. Messages are often implied, but not plainly expressed. For high context communicators, it's often what isn't said that is a primary message. Generally speaking, high context communicators tend to be more relationship oriented, and in high context cultures, direct refusals are generally considered unacceptable. Rather, if somebody is saying no to a request, they will imply a no without stating it explicitly. So some examples, or one example, we've been seeing some changes. At this point, our focus is on keeping your father as comfortable as possible. Right now, the most important thing is making sure he is surrounded by support and care that aligns with what matters most to him. What I've heard from doctors who have attended my workshops, they've said that in the medical system, when doctors start using high context language, it's generally when discussing difficult subjects like end of life care, terminal illness, or maybe palliative care. Inuit often express their emotions very subtly in the tone of voice or the lifting of eyebrows, while appearing to be almost imperceptible to the stranger. Inuit are adept at picking up the slight intonations and facial expressions that reflect emotional states. So this is part of being welcoming. Part of being respectful among Inuit is moving quietly, talking quietly, not expressing views too strongly. So we'll look at the communicating scale. You'll observe in this scale on the left-hand side, we have low context communicators, and on the right-hand side, we have high context communicators. In the world of cultural psychology and CCC, Euro-American and Euro-Canadian cultures are generally considered to be the most low context in terms of their approaches to communication. Inuit tend to be more high context, along with Chinese, Japanese, or Indian cultures. So some examples of Inuit high context communication. For Inuit, the way we demonstrate agreement is by raising our eyebrows. So if you ask an Inuk a question and they raise their eyebrows, that is a nonverbal yes. And if an Inuk responds with a scrunched nose, as I'm demonstrating, this signals disagreement. So keep an eye out for those if you're working with Inuit patients. We'll go through this example of what high context and low context communication might look like. It's not specifically medical, but it does illustrate some of these concepts. Here we have a manager and a worker talking to each other. Manager says, I need you to come into the office on Saturday. Can you do that? The worker says, yes. The manager says, great, thanks so much. The worker then adds, did you know Saturday is a very special day? It's my son's birthday. That's wonderful. Wish him a happy birthday for me. The worker says, okay. So let's break this down a little bit. Let's assume the manager is a low context communicator. And this is a pretty safe assumption. I need you to come into the office on Saturday. That's pretty task oriented, but it's also because of the way they frame the question. Can you do that? So for low context communicators, because it's okay to say no, it's okay to put other people in a position to say no. So let's assume first that the worker is a low context communicator as well. If a low context communicator says yes, we can take them at face value. So it would be reasonable to assume that the worker is going to come into the office on Saturday. However, if the worker is a high context communicator, let's remember, for high context communicators, they're more relationship oriented, their communication is more implicit, they don't like to say no. So when faced with a closed-ended question, high context communicators are put in a bit of a difficult situation because they're generally not allowed to say no. So they will often say yes, but then try to provide additional context. Did you know that Saturday is a very special day? It's my son's birthday. This is what we call an implied no, or an implied or an indirect refusal. What the worker is trying to say, remember, between the lines, is often the primary message. Even though they're saying Saturday is a special day, it's my son's birthday, what they're really saying is I've already made plans and I'm not available to attend. Let's look at this line. That's wonderful. Wish him a happy birthday for me. If the manager is a low context communicator, that means, okay, it's your son's birthday. That's great, but I still expect you to come in. But if the manager is a high context communicator, that's wonderful. Wish him a happy birthday for me would be code for you don't have to come in tomorrow. So when we're looking at these kind of dialogues and when we're interacting with people, we have to develop the skill of determining if our audience practices direct or indirect communication. Here's another example. A Euro-Canadian public servant is teaching a week-long workshop in Iqaluit during the summer. All of her students are Inuit men who are also hunters. One day she walks into her classroom and sees only one student. She asks, where is everyone? And his response was, there's seals in the bay. And so we have to consider, what is the context behind the conversation? 1, food prices in the north are very high. 2, practicing traditional skills is considered important. It's an important part of identity, but it's also important for healing and well-being. And so based on this context, we have to start considering what's the student implying. 1, there's seals in the bay is code for everyone is out hunting. That's sort of the obvious message. But there's also a hidden request in there too. Can I go hunting as well? So with high context communication, you can have multiple messages. So there's a real skill in being able to pick up these indirect forms of communication. Along with learning to read between the lines, we also have to consider paralinguistics, or how people say things. Speech rate is fairly obvious. Everyone is aware of this. What we have to consider when working with Inuit patients is speech latency, which is a lag time between when someone asks a question and another person responds. Generally speaking, Inuit tend to have longer stretches of silence when we interact with each other. If I ask another Inuk a question or if I make a statement, I don't expect them to respond immediately. Rather, I give them the space. It could be a few minutes. It could even be a couple days before they respond to my question. This is very different from Euro-Canadian interactions, where generally speaking, Euro-Canadians are very uncomfortable with silence. There's minimal speech latency. Generally speaking, in Euro-Canadian culture, if somebody asks a question or makes a statement, the audience or whoever is responding will answer as quickly as possible to avoid, we might even call it dead air. And expressiveness, this refers to the intensity and volume of body language. This is illustrated in things like nonverbal cues such as facial expressions, hand gestures, and body movements. I've heard from some of my non-Inuit colleagues that when they listen to Natan Obed, this is a picture of Natan Obed, who's the president of Inuit Tapere Kanatami. He talks about these serious issues facing Inuit, but when he talks about them, he often talks about it in a very neutral tone of voice. And I've heard from non-Inuit say, well, he seems completely disengaged or disinterested, that he doesn't really care what he's talking about because there isn't any anger, there isn't any expressiveness. But this is part of Inuit. This is part of the unspoken rules that Inuit follow when we interact with each other. We have subtle facial expressions. We don't talk too loud. We don't talk too fast, and we give people a lot of time and space to respond. I'm going to switch the next couple slides in the interest of time. But one of the things we need to be mindful of when working with Inuit patients, as well as with anyone from a different cultural context, is false consensus effect. This is a tendency to see one's own behavioral choices and judgments as common and appropriate to the current circumstances, while viewing alternative responses as uncommon. So generally what this means is, if we're a low context communicator, we assume everyone practices low context communication. If we're a high context communicator, we assume everybody can read between the lines. So some tips for working with high context communicators. It's a good idea to take time to build trust and establish a rapport, ask about the patient's family and their home community. But whatever the patient shares, have some willingness to reciprocate. Be willing to share about your own family and community. This is part of what many Indigenous peoples mean by the term reciprocity. I'm sure we've all heard this term before. So be willing to share about your own situation without making you the center of the conversation, but as a way of reciprocating this openness. Also, if a patient has an Inuk name, you can ask if the name means anything or if they're named after someone. So my name, for example, Qamaniq, I have two Inuit names. One is Qamaniq, which means the part of the river that becomes very slow. And I have another Inuk name, which is Kaukwaljuk. Kaukwaljuk was, a long time ago, he was a shaman whose spirit animal was a polar bear. So asking about family, asking about community, asking about names, very safe topics to discuss. And it's also a good idea to develop comfort with speech latency, allow for pauses, resist the urge to fill gaps. This is what many indigenous people, including Inuit, mean when they talk about having space, is having some time and a bit of space to reflect before answering. So resist the urge to fill these gaps. You might have an urge to restate your question, maybe reframe it, or give a helpful example. Keep in mind that there could just be different norms around pauses in speech. Pay close attention to facial expressions and body language. Practice active listening. Inuqatigit means being sensitive to other people's emotional states as well as their non-verbals. So if you're asking questions, make sure to look at someone at an Inuk's face to see if they're raising their eyebrows or if they're scrunching their nose. And if you have to make a request, make sure to leave a note. So some traditional Inuit views on food and healthcare. In terms of traditional food consumption patterns, so Inuit traditionally followed a subsistence-based hunter-gatherer lifestyle, and this had an impact on eating patterns. You ate when there was food, and if there wasn't food, then there was some hunger and starvation. So we didn't have this, we didn't have the same European notion of having meals at a regularly scheduled time. This had an impact on eating patterns. And there was also a role of cravings in traditional Inuit health, because back then all of the edible food was safe to eat. And Inuit were very sensitive to the needs of their body in terms of nutrition. Part of the traditional knowledge was, and this is what Inuit elders will say, is that if you have a craving, that's your body telling you that you have a nutrient deficiency. And so cravings could be for specific animals, could be for specific organs. And elders would tell you if you have a craving, that's your body telling you you need a nutrient. So you have to satisfy that craving. And that craving was important for traditional health. Doesn't really work well with our highly processed and addictive foods today. There were also traditional views on weight gain. Traditionally, many Inuit believed that gaining weight was healthy, and many Inuit still today will say, I'm putting on weight because my grandparents told me that this is what is healthy. Now, there's a lot of conflicting views on the importance of weight gain, but traditionally speaking, having some weight was considered healthy because one, that meant that you had a lot of food to eat, but also fat was important for keeping warm and for emergency energy storage. And there is a lot of evidence, I've listed some studies here, that there are a lot of studies that suggest that populations which have adapted to cold climates may have a higher capacity for brown adipose tissue activation. So brown adipose tissue, it plays an important role in thermogenesis, which generates heat and maintains temperature in extreme cold environments. This aligns with traditional Inuit knowledge around weight gain, that Inuit may be predisposed to developing brown adipose tissue, and this in fact is healthier and essential for survival. And there's also this relatively recent notion that food can be unhealthy but edible, things like junk food. This is a fairly recent notion for a lot of Inuit who are recently colonized, and we're still kind of sorting this out, that there can be food that you can eat, but it's unhealthy, because traditionally, if there was food that would be inedible, these would be kind of organs that aren't safe to eat or parts of an animal, then people would avoid those. But now in modern society, we have food that are intentionally made to be addictive, but are also unhealthy. In terms of views on healthcare, many of our views are shaped by negative historical experiences. These would be things like TB sanatoriums, poor treatment at from medical professionals in residential schools, as well as in nutrition experiments, which were conducted on students in residential schools. This has shaped a bit of a fear around the medical system. And in terms of our current experiences with healthcare, one, we have very poor access to healthcare. Within our healthcare facilities, there are high turnover rates of medical staff. We often hear stories of misdiagnoses. There are also language barriers because most people who travel up north to practice in Inuit communities do not understand the language, and this creates barriers in terms of healthcare access. And many Inuit report experiencing racism and discrimination in healthcare settings. There's also, similar to the recent notion of food that's edible but unhealthy, there's also these notions of a family doctor. I myself, I did not know what a family doctor was while I was growing up. Even the term family doctor was very confusing for me. I heard it in TV shows. When I heard the term, I thought, wait, so that family has a doctor that only serves them? It was very confusing for my child brain and for my English as a second language brain. But also, because of the high turnover rates of medical staff up north, there aren't regular family doctors. It's very unusual to think of a family doctor, to think of somebody who knows your family medical history, not only of yourself, but of your parents, maybe grandparents. And also, traditionally, we only sought the aid of healers when we had illness. So regular checkups is a relatively recent notion. And there's also a lot of confusion about the iterative nature of diagnosis. One, it could be paired with confusing medical terminology or jargon, but often the way diagnoses are presented, that is to say, if you present your diagnosis in a very confident tone of voice, even if you're not entirely sure, can lead to confusion. And when the diagnosis changes as we get more information, this leads to a lot of confusion too. And Inuit patients think, wait, you said with so much confidence that it was this, but now you're saying with the same degree of confidence that it was this. And this will lead to some mistrust as well. So we'll move on to our next scale, the disagreement scale. This scale looks at confrontational and conflict-averse approaches to disagreement. So we'll define the two ends of the scale, and then we'll see where cultures are situated. First, we'll define confrontational disagreement. In confrontational cultures, disagreement and debate is considered positive. Open confrontation is appropriate and does not negatively impact relationships. And in confrontational cultures, negative feedback is often clear and direct. So as an example, maybe we have a patient that we're frustrated with. We might say something like, you've missed several appointments and haven't been taking your medication as prescribed. This is why your condition is getting worse. If you don't start following recommendations, you're putting your health at serious risk. So again, if you observe this language, it's clear, there's no ambiguity, it's explicit about the issues. It also tends to focus on specific issues rather than on behaviors. There isn't a lot of generalizations, and there's no sugarcoating. The tone tends to be more straightforward. There's no attempts made to soften the message. We see this type of communication more in confrontational cultures. Looking at the other side of the disagreement scale, we have conflict-averse disagreement. In conflict-averse cultures, disagreement and debate is considered negative. Open confrontation is inappropriate. It disrupts group harmony and negatively impacts relationships. Negative feedback is avoided or indirect. So as an example, I noticed it's been a while since your last appointment. It seems like your medication hasn't been taken consistently. That might explain why your symptoms aren't improving as much as we'd hope. Maybe we can find a way to make the routine easier for you. So looking at this approach to giving negative feedback, we can observe that there's a lot of mitigating language. Maybe, it might help, it could be. This softens the feedback. It makes it less direct and easier for conflict-averse peoples to accept. So here's our disagreement scale. Inuit tend to be quite conflict averse. We tend to be quite extreme in our aversion to conflict. We don't like to openly disagree. We don't like to propose an idea if it contradicts another person's idea. And we're very subtle or indirect about giving negative feedback. Euro-Canadian culture tends to be more in the center relative to other cultures, such as Israeli, French, or Russian cultures, which tend to be more direct in how they give negative feedback. Most Euro-Canadians I talk to, or even most people who live and work in Canada, generally consider themselves conflict averse, but it all depends on which cultures you're comparing it to. I'm sure we've all heard the term cultural relativity. One definition is that what's acceptable in one culture isn't acceptable in another. Within CCC, cultural relativity means, well, which cultures are you comparing? Even though the Euro-Canadian approach to disagreement is conflict averse relative to, say, Italian cultures, it's still quite confrontational relative to Inuit cultures. So what we think of might be soft might be considered aggressive relative to other cultures. Here are some examples of how people might say no. This is an image from Sheena Nova. She's a TikToker who talks about these Inuit social norms. Her and her friend are demonstrating the Inuit nonverbal no, the scrunch nose. So the way Inuit might say no, if you ask, are you available, tomorrow at 4 for an appointment? A conflict averse no might be, I have to unlock the door for my kids. That's code for my door is locked. Kids are coming home from school. I have to unlock it, so I'm not available at 4. My family is in town is code for I have plans. Shrugging or saying I don't know or maybe, generally considered to be a conflict averse way of saying no, if you want me to, or as is socially acceptable in Inuit culture, ignoring someone or looking away is considered more respectful than saying no directly to someone's face. So I'll remind everyone about non-interference again, about how everyone is free to live their lives free from interference with others. The value placed on a person's independence affects the way requests are made between Inuit. Direct requests are considered rude and aggressive, so a guest may make their wishes known by making indirect hints. This oblique way of making requests allows a host to refuse a request by pretending not to get the hint or to simply ignore it. So traditionally, if Inuit wanted to make a request of someone, we would make an indirect hint, and if our audience isn't able to agree with that or satisfy that request, it would be socially acceptable for them to ignore that request or to pretend to not get the hint. So some tips for managing disagreement in a cross-cultural setting, or if you're working with Inuit patients, ask patients one question at a time, keeping in mind speech latency that they might need a little bit of time to respond. Avoid double negatives, technical terminology, or colloquialisms. One example of some English that many Inuit find confusing is the question, do you mind? Do you mind if I do this? Many Inuit find this very confusing. I'm sure people who speak English as a second language find it confusing as well. Do you mind if I talk to your family? It's confusing to respond to that question with no, to indicate that it's okay to talk with family. So avoid do you mind. Knowing how to respond can be very confusing, as well as things that we might hear in a healthcare setting. Your numbers are a little off. That might be confusing. Maybe if we say that, we expect a patient to ask for clarification, or terms or colloquialisms like it's nothing to write home about. People who aren't from this cultural context might find that confusing. It means it's, something isn't serious, but some people might be confused about that. If you do have to make a request, make sure to leave an out. And practice identifying indirect refusals. So here's an example of a request. Can you come back tomorrow for a follow-up appointment? We notice they didn't leave an out there, and the patient says maybe, which is code for no. One of the things that you can do to make a culturally safe space is to tack on this out? Can you come back tomorrow for a follow-up appointment, or are you busy? Because if you leave an out, then that gives your audience or your patients an opportunity to take the out without having to say no. I might be busy. That would be code for I'm not available. One of the things we have to keep in mind is cultural identity conflict, not only for ourselves, but for the people that we're interacting with. CIC is experienced when behavioral demands from attachment to multiple cultures contradict each other. Essentially, what this means is if we're expected to behave in a way that goes against the social norms that we were socialized in, this creates a deep sense of anxiety. In research with immigrant families and international students, CIC is associated with increased mental health distress, depression, anxiety, suicidal ideation, academic failure. And the smallest, most innocuous things can cause cultural identity conflict. For Inuit, sitting in silence doesn't create any stress or anxiety. This is by no means like based on this graph isn't from any sort of quantitative research. I just created this to illustrate what could cause cultural identity conflict. So for Inuit, sitting in silence doesn't create any stress, but I've observed that in Euro-Canadian society, sitting in silence can be a big source of stress. So speech latency can cause cultural identity conflict. Opening a door without knocking. For Inuit, this is how we were socialized. I think it's more common in very small towns and villages too. But for out-of-towners, being expected to open a door without knocking can create a spike in stress. Openly disagreeing, not a big deal for confrontational people, but for conflict-averse peoples, saying no, proposing an idea that might contradict someone else's idea can create elevated levels of stress. Even making direct requests. For direct communicators, direct requests, it's easy to make a request. It's also easy to say no to a request. For indirect communicators, making a request directly can be quite stressful. Okay. And very quickly, I'll just talk about confidentiality and collectivist decision making. Generally speaking, Inuit tend to be more collectivist. How does this manifest? So immediate and extended family members may have a say in a patient's treatment plan. So because Inuit are collectivists, Inuit patients are less likely to be concerned with patient confidentiality. As an Inuit patient, I wouldn't be too concerned about my siblings finding out about my health condition. I'd be okay with doctors talking about it openly amongst my family members. Patients may even undergo treatment that they personally disagree with out of respect for a family member who holds authority. So if a grandmother believes that a patient should take the treatment, even if the patient doesn't want to, the patient will agree to undergo that treatment. Here's some notes from Cancer Care Ontario. Indigenous patients may have large number of visitors. Family members may have a responsibility in decision making. This is part of this consensus-based decision making. Furthermore, there might be situations where no one person in the family makes independent decisions. Regardless of an illness, an Indigenous person may decide to stay in his or her community with supports and family members rather than risk dying alone in a hospital or an unfamiliar community. Many Inuit patients will prefer to travel home to stay in palliative care among family rather than staying south, where they might get another couple weeks or a month or two longer. And so, summary of recommendations: practice using specific Indigenous terminology. So that means specific nations or Inuit, Métis. Avoid Nunavut centricity when working with Inuit. Inuit might come from different parts of Canada, different parts of Inuit Nunangat. We have to take a trauma-informed approach. A good percentage of the Inuit population is dealing with issues of intergenerational trauma. We also have to practice identifying our patients' communication styles. Are they low or high context communicators? Are they confrontational or conflict averse in their approaches to disagreement? It's also contextual too. There's some areas where it's okay to be low context, some areas where it's okay to be high context. It takes a lot of skill to be able to differentiate that. Observe your paralinguistics, speech rate, speech latency, and expressiveness. If you observe that your patient is maybe talks a little bit slow, maybe leaves a bit more silence, maybe very neutral in terms of their expressiveness, how might they perceive you? Maybe they see you as someone who speaks too fast, who doesn't leave enough silence, who's too aggressive in terms of their expressiveness. And also observe how your patients makes in response to requests. Are their requests direct or indirect? And if they refuse, is it direct or indirect? And for sure, you'll need to utilize cultural informants. These could be interpreters, anybody who has a foot in both worlds, or someone who's maybe been up north or interacted with Inuit on a significant, in a significant way. Definitely use those people. Otherwise, you're going to miss a lot of the subtle nuances, the idiosyncrasies of nonverbal communication. Okay, so I've gone a little bit longer. Let's go to questions.
Amazing. Thank you so much, Kevin. That was an incredible talk. I love how you took us on quite a journey from the context and the history all the way through to very specific examples and some detailed things to consider. Especially, I loved the "do you mind" phrase. I think even our children in my family have trouble with getting that one sometimes. So we're going to take questions. Um, and Kevin, if you want to stop sharing, you can do that, and then we'll have some
Yep.
more things to show. And everybody, if you haven't had a chance, you can go to slido.com, and the code is ISARCS. And I'm going to get started on the first question. So this is respect to high and low context. If you aren't sure the meaning, high context situation, how can you be respectful and still clarify and make sure you're understanding the significance of what the individual is saying? For example, can I ask, that's wonderful that the seals are in the bay. What does that mean for you?
Yeah, for sure. If you don't know how to read between the lines, this is one of the limiting factors of high context communication, is that it only works for other people who have the same context. It doesn't work for people who don't have shared context with. So for sure, ask follow-up questions. You can even be a little bit self-deprecating. You can say something like, "I'm sorry, I'm not from here. What does that mean?" And just ask some follow-up questions. That's totally fine. This might be met with some confusion because in the example, there's seals in the bay. Both parties felt that they were being very clear. They were following their respective rules of good, respectful communication. But it's not until we interact with people that follow different sets of social norms that we have these what are called cultural miscommunications, where people are speaking the same language, but they interpret things differently. So in situations like that, it's better to, if you don't have a translator or a cultural interpreter, for sure ask follow-up questions. Be a little bit self-deprecating. Um, don't try. I've observed in Euro-Canadian culture, it's very important to have a professional face where you seem like you know all the answers. And um, in Inuit culture, it's better to practice openness, where if you're not sure of something, then you just practice high disclosure and you just say, "Oh, I'm sorry, I don't know what that means. I'm not from here. What does it mean that there's seals in the bay?" For sure, ask follow-up questions.
Amazing, thank you. Next question. I'm a midwife. I currently have two Inuit women in care. Are there any prenatal labor postpartum traditions that I can inquire about if they desire?
Right. I don't really know too much about this, about traditional postnatal care. Um, it's probably quite different from Euro-Canadian approaches to postnatal care. I can share a little bit about what my mom told me, not about postnatal care, but around traditional norms around the birthing process. My mom was told that when she was giving birth, maybe you'll observe this if you're working with Inuit. Inuit were told to never make a sound when you're pushing. No matter how much pain you're in, you have to bear it quietly. And this is what my mom did with all five of her children. She gave birth without uttering a peep. So I know to that much, but I don't know much about traditional postnatal care. I'm sure there's resources out there. And maybe you could ask them too, right? Ask your midwives, ask if they know anything. Inuit who have access to traditional knowledge or no traditional knowledge are always excited to share that. So I encourage you to ask the midwives that question.
All right, excellent. Next question. I'm going to need you to interpret this first word for me, but the writer says, Nakumik for this space, recognizing the critical importance of establishing trust after the many harms done by the colonial health system. What strategies would you advise healthcare providers who are coming up to Nunavut for locum placements to build relationships, knowing their stay is very transient?
Right, excellent question. And that first word, Nakulmik, that's how South Baffin Inuit say thank you in Inuktitut. So, Ilali, you're very welcome. In terms of locums and traveling up north for a brief stay, some of the things that you can do is that you can practice some easy Inuktitut pronunciation. There's a lot of guides available online, basic greetings. One such guide is tusalanga.ca. There's lessons on there about how to say basic things like good morning, how are you doing? I'm fine. So practicing your Inuktitut, very basic Inuktitut. You don't have to be fluent. Just just putting in the effort of practice will be seen as a positive thing. People will see that and they'll say, oh, this person means business. They're not just here just to make money. They actually really want to help. Another thing that you can do is there's a couple of helpful resources that you can read. One I've already shown is Pagtutit's The Inuit Way. If you do a search online, I include in my slides, which I assume will be made available to everyone, a list of resources. Paugtutits, the Inuit Way, there is a PDF available online. There's a lot of great reading there. I personally find it very helpful and informative, not just for the people that I work with, but also for myself and for my own internal sense of identity. And really, one of the biggest things that you can do is you can become sensitive to your patients or the people that you're working with. So what does this mean? This just means being mindful of the nonverbal communications, being mindful of raised eyebrows, scrunched nose, observing how much speech latency they provide. So if you ask a question and say somebody takes 5 seconds to respond, you can reciprocate by giving them 5 seconds as well. You ask a question, they wait 5 seconds, they give an answer, you wait 5 seconds, and then you respond. One of the most useful skills is being able to sit in companionable silence. This is going to be very difficult, so you need to have a plan. You can have a fidget, but it would have to be like a fidget that isn't loud or aggressive or very fast. I'm sure there's some fidgets available out there. One of the tips that I often give people is to, if you have a drink, I don't know if that's socially acceptable in a medical setting, but if you have a drink, you can ask a question and make a statement, and then you can give some space by, looking away a little bit, keeping your expressiveness, the volume of your body language down. Don't make too much eye contact. And so observe how much eye contact people make. Generally, when Inuit interact with each other, we will briefly make eye contact to establish connection, and then we'll look away. And then a couple minutes later, or if there's a change in subject, we'll briefly make eye contact and then we'll look away. There isn't this prolonged eye contact. Observe all of these nonverbals and try to mirror them as much as possible if you're comfortable to do so. If you're not comfortable, if you start experiencing cultural identity conflict, then you have to recognize what your CIC triggers are and you have to come up with plans to mitigate them. Could be having a fidget, could be having somebody there to kind of act as a neutral third party, could be having a drink, taking a drink, looking out the window. It could be anything. But if you can learn to sit in silence and become sensitive to nonverbal communication, then this can go a long way towards improving your relationships, not only with patients, but with community members as well, other Inuit healthcare staff that work in the hospitals and the nursing stations.
There, I just practiced 3 seconds of silence there between starting again. So, understanding the collectivist nature of decision making, how would a healthcare provider tackle a possible conflict between what the client wants, say an adult patient, versus the wishes of the family who has authority, say an elder? How can we ensure respect both in client and culture?
So one of the things that you can do is if you talk one-on-one with a patient, you can let a patient know, you can say something like, this is about what you want. This is, and in individualist cultures, we're all about individual autonomy and personal expression. So you can try to convey that message. It's probably not going to land, right? Because then we're asking our collectivist patients to go against their kind of collectivist social norms. Saying something once doesn't make it true. Even saying something several times doesn't make it true. But if you get a chance, one-on-one, you can say, you know, this is your choice. If you want the treatment, go for it. If you don't want the treatment, that's fine. It's all up to you. You can say that. Your patient is going to say, okay, they're going to, maybe they'll even share what their preferred option is. It's all going to change once the family is back in the room. So you can ask, you know, remembering to leave a note. Do you want to have this conversation alone, or would you rather your family was here? Or you could ask another way. Do you want to have this discussion with your family here, or would you rather talk about it alone? Remembering to leave that out. Even if you do everything perfectly and you create the perfectly culturally safe space and you ask things in the right way, that doesn't mean that your patient is going to practice autonomy in their decision making. It's very hard to change your social norms. This is what makes assimilation so painful, right? Especially forcing people to change their behaviors. You can do what you can to let people know about their rights. You can ask out of politeness and respect, but try not to be too assertive when you're making these suggestions and recognize that even if you do something right, they may still decide to go with whatever their grandparent says. It's very difficult to change the social norms that someone follows.
Thanks, Kevin. So we have maybe time for one or two more questions. So could you speak to the perceptions of mental health and wellness, help seeking preferences, and integrating traditional wellness strategies with psychiatric care?
Yeah, that's a great question. One, there's very poor access to psychiatric care in Inuit Nunavut. Um, I can talk a little bit about what it looks like in Nunavut just because that's where I'm from, but often there isn't much in terms of access to psychiatric care. We often have, um, if we do get a psychiatric professional or a psychiatrist up north, they might just go up briefly and everybody will try to get their appointments in on time and they'll be overwhelmed. Occasionally, you'll have someone that will do a little tour around, 4 or 5 communities over the course of a few months. But access to psychiatric care is very difficult and and it's also inconsistent. And in terms of how it squares with traditional Inuit norms or traditional Inuit practices about mental health, most Inuit traditionally will say, if somebody has some sort of mental imbalance, then they need some land-based programming. They have to be out on the land. Maybe they have to do a bit of hunting. Maybe they have to sew. Some sort of cultural activity, maybe make their own tools or sew their own clothing. It could be sewing or beading, could be carving, could be working with soapstone, some sort of traditional activity, culture as healing, right? As it's often called. And it usually comes in the form of land-based activities. One of the other things, and I think this is a bit of a cultural incongruity too, I think in the South, And in the Western world, if somebody suffers from mental health issues, maybe it was a kind of an old-fashioned notion to try to isolate them from people as much as possible. We would have a different view of that. If somebody is suffering from mental health issues, they need to be around community more. They need to be around family. They need to know what their role is within the community, and we have to give them the tools and we have to empower them to kind of take on their role within society. Also, country food is often considered very healing. Country food is what we call traditional wild game. Many Inuit will say um, that country food, not only is it nourishing, but it's also healing for the spirit too. So land-based programming, um, being surrounded by loving family and community members, access to elders too, and traditional knowledge, as well as cultural activities um, and country food. These would all be considered traditional ways to heal someone with mental illness.
Thank you so much. Okay, we've come to the end of the webinar now. Kevin, you did just an amazing job with those questions. Thank you. I'd really like to express my sincere thanks and gratitude to you, Kevin, for such an excellent webinar. We didn't get to all the questions, but we thought we might not because we have so many participants and it's such an interesting topic. So I also want to acknowledge the hardworking UBC CPD staff, without whom the delivery of these webinars would not be possible. If everybody could take a moment to complete the attendance and evaluation forms that were emailed to you, or you can see the QR codes here, and reminder that you can get 1.5 credits if you fill out the attendance form. In the coming days, you'll be receiving a follow-up email containing tonight's webinar recording, as well as a link to any of the resources mentioned. And finally, if you've enjoyed this webinar, you could register for our next webinar on May 14th on the topic of allyship and upstanding, interrupting Indigenous specific racism in healthcare. And we hope to see you there. Well, we're going to end it there. Thank you so much, Kevin, and thank you, everybody, for attending and taking time out of your applicable, helpful, and really comprehensive. Thank you.